we'll go ahead and get started. Obviously, I think some of us know each other kind of from the data community. I think most people probably know who Kurt and Susan are. Hopefully, a lot of people know who I am as well that are in here. Rick, on the other hand, he's a little bit of an outsider, and the reason that we invited him into this panel is because Rick is an MD, and Rick has been writing quite a bit about the COVID-19 situation recently, and so we thought it would be a great opportunity to get him on and talk from his perspective about some of the same issues that we're kind of talking about in the data world. And and obviously we wanted to bring Scott on as well because we're kind of viewing this problem very much as a data problem, much more than perhaps a public policy problem with a lot of the things that we are dealing with. And so that's kind of the whole concept of what led us down this path. So I'll do a real quick introduction. So Dr. Rick Bathello is a family physician and professor. He developed an interactive webinar prototype to educate people complexity thinking to address the VUCH-19 crisis. For Susan Walsh is the founder of the classification guru, fixer of dirty data. She is a specialist in data classification, supplier normalization, taxonomy development, and data cleansing. And Kurt Cagle is an author in the journal of the Cagle Report. He's written for a number of publications, including Forbes, Medium, O'Reilly, and has worked with multiple Fortune 100 companies and international agencies on issues of data management. Kurt is focusing on future technologies, science, enterprise data management, and technology ethics. He also runs his own consulting company, Semantical LLC, specializing on smart data. So as we were kind of talking a little bit informally just a few minutes ago, the reason why we wanted to discuss this as a panel is to dive into the idea and the processes and issues that are currently floating around in the ether between medical workers, policymakers, and the general public. And we can go into a plethora of issues which we have been documenting kind of along the way, that we are looking at almost all of these things as data issues, and this is a common theme certainly for anybody that is involved in public policy or dare I say stakeholders, to take some of these issues with data quality, more or less cherry pick the data and then run with it, and then and then ultimately use that to influence public policy decisions, right? So this is one thing that we wanted to be able to evaluate here, but we don't want to turn this into a public policy discussion per se. The reason that we wanted to look at this as a topic is the same thing that we see happening right now in the public sphere. This is something that we see happen in most, or dare I say, all large organizations. Whenever some new crisis may happen, maybe it may not be a public crisis, but maybe it's a company crisis that sends them into reactionary mode, and somebody needs to go figure something out. Maybe an analyst published a report about the company, or maybe there was something like a drought or a riot or something like that that's ultimately going to maybe influence our stock price or maybe impact our supply chain or something like that. And as a result, it starts this process, which is somewhat of a fact-finding process inside of the organization, and the ability to successfully complete that fact-finding organization is really dependent on our ability to collect and analyze the data, which also requires the data to be of rather high quality in order for us to be able to do that. Unfortunately, that's not usually the case. And so that is the angle that we are taking with this, with kind of this crisis. And so we have a lot of rabbit holes that we can go down as we go into this topic. And as I mentioned, we do have quite a number of some very specific measures and metrics that we can kind of dive into about things that we know are wrong or are poor data quality related to the collection and data reporting related to COVID-19 and the way that it's reporting, the way that it's being reported to the media. So I kind of wanted to open the floor to discussion and and get everybody's thoughts on how, not only how this is impacting the current COVID-19 scenario, but how this can ultimately, or what lessons we can ultimately learn to take this and apply to companies. So if anybody would like to jump in, I'm sure Kurt probably has some thoughts.
Actually, a couple that I've been thinking about quite a bit lately. One of the fundamental issues that I've seen, and one of the things that I found so remarkable about this particular crisis has been that it has effectively accelerated what I see as already extant trends by about 5 years. It's not, in some respects, one of the things that I find so remarkable is actually how easy it has been for organizations to make the transition to a pretty much fully digital environment. We're talking 2 months, and many organizations just dropped right into that particular role, that particular capability. And I got to thinking about that, and it occurred to me that the reason that was the case was because these trends have already been in place. We were already moving in this direction. We just needed to have an impetus to basically take away the social inertia that would have been involved, that normally would have taken maybe 4 to 5 years of regular development to get to a stage where we can now look at it and say, okay, this is the way things would have been in 2025. Well, it's 2025, about 5 years early. And so I think that that factor has kind of highlighted areas where there's, where we've actually been quite successful, as well as highlighting areas where, okay, maybe we do need to think a little bit more seriously about how we handle data. So I'll give up the floor to everyone else here. So.
Well, I would say that I think one of the biggest issues was that there were not really any processes in place before this started for their regular daily business. So when this came about, they didn't really know where to start. They didn't know what the end was going to be. So they just jumped in and said, let's just do it without really thinking about having a strategy or a plan in place. So I think that is going to change a lot of not just healthcare organizations and governments, but businesses in terms of having a good data strategy, data governance, all those good things that we like to talk about.
And Rick, what are your thoughts on
Well, I mean, this is such a broad range of issues to think about. But one thing that I think is well worth looking at, and there is good data out there for it, is the death rates by countries. There's a website which I can share where you can go and look at, what's the death rates, what's the admissions to ICUs, what's the number of people who end up on the ventilators by countries, and it's dynamic, it's updated on a regular basis, and it's fascinating to see the wide variance of death rates. For example, Belgium has, and nobody talks about Belgium,
wow,
has the highest death rate in Europe at the moment. Yes. Sweden, for example, which you've probably heard, they've been somewhat lax in their shelter in places. Is not been as bad as what one would have thought, and it might say something more about the Swedish culture and people's general sensibilities about how to take some precautions, but not everything. Oops, sorry about that. And then if you look at the Asian countries. Look what happened in New Zealand, Australia, Taiwan, Singapore, Hong Kong, South Korea. I mean, nobody's talking about this. There is good data out there, but nobody's talking about why is it that there are certain countries, one of whom is the States, is doing so poorly. So I think there is data out there, and it's a question of how the data is used, and it's sometimes turned into misinformation. Sometimes it's used for disinformation as well. So one of the challenges is how to use data well and have a rational discussion about why there's these
I would
huge
say that
differences between
unless
countries.
we knew that every single country was collecting the data in exactly the same way, it's very hard to compare it like for like. So there might be good
Absolutely.
data,
I
but
agree with you. But
it might not be comparable. So I don't think we really have a true picture of what's going on.
Well, I couldn't agree with you more that you have to look at the even when you say somebody dies of COVID, is it really COVID or something else? There's a lot of variabilities. But when you see the magnitude of scale of differences, even when you take in the error rates that are there's going to be variable error rates and whatever in different countries. They're so huge that if you just take the Asian countries I mentioned, Australia, New Zealand, and compare it to Europe. And you just look at, well, are the hospitals full? Are they overflowing? You can corroborate the evidence with, what's in the media. So even though the data is crude, there's still some data out there.
I was on a panel a couple of weeks ago that was out of the EU, specifically looking at much the same information that we're discussing here. And one of the issues that kind of came out from that was that while there was specific guidance, and the panel itself basically talked about the interaction between data coming in from through the processes, as well as data coming in specific, or as well as the role that you had with GDPR in terms of determining, exactly what kind of privacy is attached to that data and how that was getting reported. And one of the things that emerged as part of that, and I think we saw the same thing in the United States, was that because you essentially have what amounts to a federation of states, the assumption really going in was that the states themselves were responsible for their own data collection as well as their own health strategies. And it was this, in general, either the lack of desire to necessarily dictate from above the specific standards for which you needed to have that information, and as Susan pointed out, the need to be able to have consistent ontologies for being able to identify exactly what we mean by a death in COVID, or that someone was essentially COVID positive. Most of that ambiguity basically meant that it essentially devolved upon the states or upon the member countries to be able to handle their particular reporting. And because of that, it was really, the responses were very much across the board, which kind of raises the question of, and not to get, and to avoid the question that Scott first pointed out, because I don't want to get into a policy discussion. But we do need to basically make sure that, as we pull out of this particular issue, as we pull out of the COVID space, that we use it as a lesson to be able to say, well, data standards matter. And the ability to identify, define, and in some cases define very quickly what kind of protocols we're wanting to be able to collect in the case of things like a disaster, a pandemic, a flood, so forth, are really very critical.
Absolutely, and I sorry, go ahead.
Yeah, I couldn't agree. No, I couldn't agree with you more. And the question is, if you look back, I mean, there's a concept that I'm becoming much more interested in is the whole notion of anti-fragility and the idea of having your data systems in place in advance so that you can respond more appropriately. I mean, if you look back at Bill Gates's talk in 2015 on pandemics, I mean, that information was out there. He was predicting it. He was wanting data. He was wanting, capacity to do that. So the question is, even with a call for good data, how do we actually translate that into, effective preparedness? Now, I know that gets into the political realm, which is not something that we want to waste our time on today about, but because it's not going to help. How can you advocate for more strongly? And I agree with you, Susan. You need to have much better data. And I think anytime you look at it, you always have to scrutinize, what's the quality? How good is it? Are there political agendas? Are there certain states in America that are suppressing their reporting, yada, yada, which I wouldn't be the least bit surprised isn't happening. I suspect, there's going to be covers up and all sorts of stuff.
And I think to your point, Rick, where you were mentioned to, what we think is perhaps the most accurate data that we have is in regards to the deaths. But we know that there are a couple of big issues with that, at least as we compare regions to regions. One of those is that there are a number of areas, and I think it's going to be very hard to quantify how many there are or precisely where they are, that are not admitting individuals into medical centers if they're suspected of having COVID symptoms. And so therefore they don't get diagnosed and they die outside of the hospital system, right? And so they don't show up in the numbers at all. And this is something that I heard a few weeks ago Brent Weinstein was referring to, because he had actually spent a tremendous amount of time, I think it was in Ecuador, that over his 25-year being a field biology professor doing studies down there, and they had actually surfaced a lot of things that were coming out of Ecuador in kind of real time as it was happening. And this is exactly what was going on down there, where their medical facilities were just so ridiculously overwhelmed in that area that very few cases were actually ever reported to any medical center, and they were to the point where they were, as bad as it sounds, they're not actually able to dispose of the bodies. They can't bury them. They can't cremate them fast enough. And, and I don't know how it is right now, but as of 3 or 4 weeks ago, it was so bad that they did have, quite a number of, perhaps thousands or tens of thousands of bodies that they couldn't do anything with ultimately, right? But the point is that whenever we're comparing our country to country numbers, these are things that don't show up in the data at all. Ecuador doesn't even show up on the charts for being a country that is badly affected by COVID, but it's very possible that it might be one of the worst. And I think, that's just one example of perhaps, 150 other examples that might fall into a similar type of category that don't have very robust medical systems, such that they're not able to handle these types of cases. So that's certainly one problem that I think, it exists everywhere. And it's not necessarily something that somebody is intentionally trying to suppress. It's very possible that they're just literally out of beds and they just can't take any more people, right? And and as such, you're not going to get diagnosed, you're not going to get treatment, and so on. So that's certainly one known issue that is probably happening a lot more than everybody thinks about. But again, I think it's also something that we have nothing more than circumstantial data on as it relates to how many people are actually affected. The other side of that is something that we've known for a long time in the medical community. And if anybody knows about my background, I spent about the first half of my career doing this type of analysis for health plans, systems and things like that. And this is a problem with the way that all data is collected and analyzed. It doesn't matter whether it was a death or whether you're trying to do diagnoses or anything like that. Whereas you end up passing away of, or you end up being admitted to the hospital, in for whatever reason, you have multiple diagnoses, you end up getting attributed for both. Right. And so if you come in and you have hypertension and you also have diabetes, you are both of those things. You're not one or the other. Right. And likewise, if you do pass away and you have both hypertension and diabetes, you get counted as a death under both categories. And the more diagnoses you have, the more that is exacerbated. And this is something that's always been a thing in at least the way that we do it in the United States for medical, I should say, of death. And that is different in various countries, and it will vary certainly if there's an autopsy, right? That some of that will be overridden, but certainly, autopsies don't happen in cases, and so you don't actually have a cause of death. All we know is that a bunch of conditions, you had a bunch of diagnoses, and then you passed away. And so the idea that we can specific diagnosis to that particular cause of death, especially at scale, becomes a really, really hard problem to do. And so really all that we do know at scale is that out there that have hypertension and they also have COVID, or they also have, some other, number of conditions that they might have. And we're able to kind of look at those conditions at scale and then correlate and say, it's like a lot of people might have melanoma and also have, have COVID. Are they related? We really don't know, right, until we kind of dive further into that scenario. So I guess the point is that there's there's a lot of nuance that goes into the way that the data is collected and also the way that it's compared, that makes it very hard to quantify a lot of these situations, even if we completely take the political scenario out of the mix, which I do think is a very real thing on a global basis.
I'd like to add to that. One of the things that you're beginning to see, and it seems to be one of the primary causes of death among caregivers specifically, and it's also something that you're beginning to see more and more of in terms of secondary infections, or basically cases where you have what's called cytokine cascade. Cytokines are basically and I'm not a medical person here, so I'm just basing it on what I've read. But cytokines are essentially signals or messages that are sent, chemical signals or messages that are sent through your limbic system, through your immune system, basically. That essentially are what tells the system, tells the body how to be able to fight off particular types of infections. And one thing that COVID seems to be responsible for is that when you get a large enough presence of the virus in your body, it actually causes a cascade where your body is sending out more signals than it knows what to do with. And there's been kind of an increase here just within the last couple of weeks of cytokine-related illnesses like Kawasaki syndrome in children. Kawasaki syndrome is really doesn't look like it's COVID. It's basically more perfectly healthy kids are suddenly getting very sick and dying very quickly. There aren't very many cases being reported yet, but the problem that seems to be emerging is that this may very well be a secondary effect that we're seeing, essentially coming 6 to 8 weeks after the initial infection, where if you get sufficient exposure, buildup of live virus in your system, your body is basically shutting down. It's a systemic infection. And so, this gets back to exactly the point that you've raised, Eric, in that, when you have these kind of systemic, shocks going in, it's very difficult to look at this and say, well, is this COVID? Well, no, it may or may not be, but it certainly seems to be highly related to it. And I think that's actually one of the real dangers that you run into, and we may be running into. Take a look at the Spanish flu of 1918, which I think is actually a good baseline to look at what a pandemic could effectively be. The thing that's very worrisome is that it too had the same kind of cytokine cascading effects that you're seeing with COVID. I mean, it's a flu, not a coronavirus, but it does seem to affect the body in much the same way. And if you look at the history of the 1918 flu, one of the things that was very disconcerting was that the first real wave that you had hit about 150,000 people. Or, excuse me, 150. Yeah, there was in the United States, there was about 150,000, 175,000 deaths. Now we're at 100,000. If you take a look at, above normal deaths occurring in the area, that probably puts us close to, let's say, about 140,000 there. But it was that first wave that was relatively mild in comparison. And the second wave didn't really hit until about 6 months later. And at that point, that's when you started getting into the millions of deaths that seemed to be caused largely by healthy people suddenly getting very sick very quickly. And, I hope that that's not where we're going. I'd really love this to be over with, but I'm very nervous. I think a lot of difficult.
Just to add on to that. Yeah, just to add on to that, Kurt, I listened to a WHO presentation yesterday actually on this topic, and they're not using the word wave. They're concerned about a second peak that's worse than the first. And I think that's a better way of describing it, because we don't know. The uncertainty is we don't know whether we're going to get a second hit. I mean, that is the unknown. I'd like to return back to the issue of data, though, and I did see a graph that looked at the whole issue of reporting bias about is Belgium just more diligent in reporting their deaths, or do they have a lower threshold for saying it was versus other countries? But one way of looking at it, I saw one graph which basically looked at the death rates across different countries over the past 5 years, and then looked at the death rate of all causes, and then looked also at the death rate attributable to COVID. Now, that's another way of trying, it's cross-validation of data sources to see whether, in fact, are people underreporting their COVID deaths or not. But, if you have a 5-year trend and you see a 30% increase in death rates, a 50% increase in death rates over a couple of months, but the data is saying it's only a 10% increase in deaths due to COVID, you can say, there's something that doesn't make sense here.
Or that becomes more to analyze as well, is that the sheer fact that much of the developed world has been under lockdown for a while, there's certainly going to be a number which are going to be drastically auto accidents, right? And I can certainly from at least from circumstantial knowledge of around my area, for the vast number of weeks in March and April, there were very few people on the road. And I don't know this for certain, but I certainly expect that the deaths that were drastically lower during those periods than they were at any other times, right? And I suspect that there were probably a lot of other causes that were also lower. And so the difficult thing that we would have to figure out is what were those real decreases, which I don't think that we know yet. Particularly because the reporting frequencies are not usually that, it's not usually that frequent, and it does vary depending on the jurisdiction. And so, but that's ultimately what we would need to suss out, is to say that, did all cause minus COVID decrease by 20% or some number, and then be able to ultimately add that back into the COVID deaths when we're kind of looking at all cause. And so I still think it's a hard puzzle to put together, because we really don't have all the pieces to do it.
I think had they potentially, when they set out with this, and obviously there are so many unknowns, but had they thought more about the end in mind, not just for this, but for any kind of reporting on any health issue, then it would have helped them map a better to put a better system in place to record and monitor this. I think, we're monitoring it because we have to. They haven't really thought, right, well, what do we need to know from this? And, like when you were talking about multiple causes of death. So, do you apportion a percentage of that disease, or, is it 50% diabetes, 50% high blood pressure, or do they both count as ones? And, start to think about things like that. How, let's get it a bit more consistent and a bit more organized. Then it could well have been a bit better.
Yeah, and I think that's the overall message that I have in my mind as a take, because this is this exact problem that you're describing. This is something that every organization who's analyzing it, whether it's the World Health Organization or whether it's the Centers for Disease Control or somebody like that, everybody's kind of looking at this with their own lens, as well as a bunch of independent analysts and quote unquote think tanks in organizations like that, and everybody's going to ultimately apply or attempt to apply their own statistical methods to it to try to kind of tease out the data. But as long as those methods are not consistent, we're still going to be comparing out.
There's also been a lot of, sorry. There's also been a surprising number of data scientists that that have suddenly appeared out of the woodwork, essentially going in saying, "Aha! It's my moment to be Mr. Data Science," and I think one of the problems that has come out of that is that it's also basically raised the question, to a certain extent, of and this was also addressed as part of the symposium I saw on. How do you basically determine who is an expert? How do you basically determine, when someone basically presents a model, is that model something that is truly authoritative, has accurate data, has well collected data, well curated data, or is it basically someone pulling in from the Wikipedia site or I think the New York Times has a similar site of information, or things like that, where it's someone in their basement basically doing aggregation. And that in turn basically comes back down to the question of collecting this data, particularly since it does directly impact questions like PHI, private health information, private personal information. Collecting that data is very, very difficult because it does run under the question of essentially who owns, who authorizes, who is at risk of essentially being exposed to liability for that particular data sets or those particular data sets. And so, one of the big things that I think has compounded the issue is because there isn't that level of availability there. The data that you'd really like to be able to see, which is essentially environmental factors, is what kind of genetic factors may be involved, what kind of people, information like that. That's information that's very, very difficult to be able to pull together because we've created this vast and perhaps overly restrictive environment about PHI that is, now proving to be problematic. So I'll throw that out there.
I'm in total agreement on what you're, and what specifically as it relates to HIPAA regulations. This is something that especially kind of having come from the the medical analytics community that I've been very critical of for a long time, and I feel like the analytics community in general, in that's a and when we talk about medicine, that's a much larger ecosystem than just data people. We're talking about physicians, we're talking about infectious disease experts and biologists and policymakers, and the list goes on. That it has really set us back a very, very long way in where we would have absent those regulations. So there were a lot of things that were going on in the data science space in the mid 1990s that were extremely advanced, especially for their time. And that was probably one of the, if not the first, it was one of the first areas where data science was really being applied at a really advanced level, in my opinion, where there was a tremendous amount of machine learning and predictive modeling going back, way before we knew that any of these things were. And then whenever the HIPAA regulations start hitting, all of that stuff stopped, and it stopped for about 15 years. And it's only kind of been recently that some of these things kind of started to come out of the logjam a little bit as policymakers started to lighten up and say that, okay, it's okay if you use this data in these very narrow bands, with obviously with a bunch of rules around it. Obviously, it has to be de-identified, but it's actually much more complicated than that you're actually allowed to do. And so it's this it's been incredibly problematic for the society at large, and and I do feel like we probably would be a lot farther along, absent those regulations, or had those regulations never gone into effect. We would probably be in a much better place just from an overall data point of view.
One point to that, and I think it was again an issue that was raised earlier in the symposium. The moderator for that particular panel asked a very basic question: is it truly possible to completely anonymize data? And I think that the answer to that from everyone on that panel, a number of experts on it, was no. We live in an environment right now where, you have machine learning systems that are able to pull in inferences to a degree where you can say, hey, look, there's a 95% chance that this particular person happens to be Joe Blow who lives across the street. And because of that fact that de-anonymization is actually a relatively simple proposition anymore, it does raise the specter of the fact that data privacy has to basically recognize the fact that the ability to effectively deal with identifiers, with identity, is a much deeper problem than I think we've currently assigned it.
Well, one of the discussions that I was a spectator of years ago, and this was again in the early days of HIPAA, probably 2002, 2003, because of the industry that I was in, we did have to go on a fairly regular basis and attend symposiums that were run by Health and Human Services, and these were the rule makers that were making the regulations for HIPAA. And one of the things that was commonly cited as an example is they were using HIV as one of those examples. Whereas if you have two pieces of data, if you have a diagnosis code for of HIV diagnosis codes, which I believe as of at least at that time there were 3 or 4 ICD-9 codes that were all for HIV, and you had the person's postal code, you could with about a 97% accuracy figure out who they were, because most postal codes in the United States only had 1 or fewer HIV patients in them. And so this was the example that HHS cited, in the sense that de-identifying the data is not nearly enough to you have to roll that data up to a much higher level, above zip code, in some cases even above city, because that's the same problem also with orphan diseases. And there's a lot of orphan diseases that are incredibly rare. There might only be 3 people in the country that have that disease, and therefore if you are one of those countries that only has 3 people that has the disease, you can't report numbers for it, because you might be able to figure out who those 3 people are. And so the rules change depending on how rare the condition is. And this is a problem that I believe exists now in the COVID space, certainly not at a national level, but when we drill down into a zip code level, it starts to look very much like HIV from a data point of view, where there's a lot of zip codes that have somewhere between 0 and 1 cases, or a very low number of cases. And and that would fall under that same rule-making apparatus. Whereas they said, there's 5 people in this zip code that has it, therefore you can't report these numbers. And, and so that becomes very complicated whenever you are collecting the data, because all of your data engineering pipelines, they have these rules. What's the total number of people that are affected by X condition or X diagnosis code? And if it's above some certain threshold on a per capita basis, then we have to apply some entirely different type of rule set about how we aggregate and anonymize that data. And it's not just 2 different levels or 3 different levels, it's n different levels of anonymization that we might have to apply depending on how rare this thing is. So it becomes incredibly complicated from a regulatory point of view about what we are able to do, and still stay in the good graces of the legal system. So it is a very, very complicated problem, and I hope that at the very least we can take this as a lesson, and maybe this is a public policy thing, be able to take this as a lesson and say, there's got to be a better way that we can deal with data anonymization than what we're doing, right?
Absolutely. You're on mute.
I don't think.
Thank you, Kurt. I was going to say, Rick, what were some of the other investigations that you had dived into in some of your analyses?
In terms of,
in regards to ultimately the overall discussion around data quality, and some of the pieces that go into it, whether we're talking about testing availability, whether we're talking about a false negatives, we can go all the way down the list of things that we know are impacting our ability across entities to be able to make accurate comparisons.
Well, actually, your questions made me think of something different, but let me just go in that direction and see where the conversation goes. And it has to do with there's a group out of MIT that have developed a methodology about containment, and it's really contingent on the ability to identify contact people and get them, do it and put them into quarantine. It's been a very powerful way of actually being able to contain things. The problem is you got to have the testing and you got to have the resources to do it. And it's perhaps one of the most effective strategies beyond self-protection to actually try and, thwart a second peak or even second bad wave. So, I mean, having, systems in place to be able to collect good data on that. And then that opens up the whole business about what they've been able to do in some Asian countries where, it's almost compulsory that if you've had contact, it automatically goes into an app and they can, people know who's had a contact with a COVID patient. And that gets into the privacy issue big time, particularly in the States. And that gets into, it's the whole issue of individual freedom versus, what's good for the common good. So you have this ridiculous thing going on at the moment about, you can tell people's political affiliation by whether they're wearing a mask or not, which is, obviously a stereotype that's, that may have a grain of truth in it. I mean, what's lacking really is how to use data more consistently to be able to mobilize people to be able to act in ways that work in our best interests. And it's not there. I mean, it's very divisive. You've got the states fighting amongst themselves. You've got within the states, you've got different people fighting against each other about, how to contain the virus. So, there was that one thing on Wisconsin, which got a lot of coverage where, you probably saw that, coverage of people going to the public swimming pool and, they're just, no regard for social distancing whatsoever. It was just, people packed the back and that's exactly what, coming back to the 1918 pandemic in San Francisco, what happened was they recovered, and then they said they all got in the streets and they said, "Oh, hey, we've done it." And of course, what happened? They got a second wave. So, I can imagine we're not going to get lots of little mini peaks going around the country because people have totally regarded the CDC recommendations. So I think we're heading for some rough waters ahead. But I want to come back to something else actually, which has to do with the international stuff. And I think I just read a trend report on that, and what's going to happen in refugee camps, poor countries, it's going to be absolutely devastating. Just look what's happening in Brazil. I mean, Brazil is, it's going to, run into major problems. So, this is it's going to be a very bumpy road ahead.
Well, and I think that goes to one of the. Sorry, go ahead, Kurt.
Oh, just I'm anticipating we're going to be dealing with these issues for at least the next 2 years. And unfortunately, it's, as you point out, it's going to be something that you're not. I think that the mechanisms, because we don't really understand it, because it happened to hit at the height of what I would consider, a heightened anti-intellectualism within the country, within much of the world, unfortunately. I think in many ways it's kind of exacerbated the problem because what's happened is that we have assumed, as people that by and large work with data on a regular basis and have a great deal of respect for accuracy of information, for timeliness of information, and so forth, we assumed that everyone else kind of shared that same opinion. And the reality is kind of disheartening that okay, you cannot make assumptions about the fact that people are going to act in a manner that is consistent based upon experimental evidence, just simply because of the nature of, really the nature of the political environment, the nature of communication in general. It's also something that, one factor that has exacerbated it. There was a figure I saw the other day. Something like 60% of the commentary, not necessarily the original post, but 60% of the commentary generated about COVID on Twitter is generated by bots. It's deliberate misinformation. So there is an aspect to this that we as data professionals need to be very aware of, in that we need to educate the general public to a much greater understanding about how data itself, what we mean by data, what we mean by information, and what its implications are for, not working with it. I think it's a very hard battle we're going to be facing. I spend a lot of time dealing with that particular issue, and it's frustrating.
Yeah, I'm in total agreement on that. One of the nuances that is an issue there is that there is so much inconsistent data that's coming out of various institutions, and there've been a lot of things that I've seen come across from studies that have not been peer reviewed yet that are servers, and there's a lot of things that are very conflicting studies that are coming out of different medical centers. For example, one of the things that's been discussed a lot is right, as to whether it works and whether it doesn't work. The reality is that there are quite a number of studies that have been out, that have been done out there by various medical centers that some show substantial effect, others show no effect, some show, an aggregate adverse effect. And so it's something that, just a very basic thing amongst a drug that's been on the market for almost 100 years, where, we don't have consistent data on right now. And, and it's kind of being used it is being used by all sides to support the message. But I think the reality is that as of right now, I don't believe that anybody actually knows definitively whether it's effective or what populations it might be effective at, or what criteria might make it effective, whether or not it's genetics, or whether it is whether it's environment, or whether it is a mutation, or something like that. And I just use that as one of many examples. But I think there's a tremendous number of rabbit holes that you could go down that are just like that, where we can look at conflicting data coming out of various entities all over the world about the exact same thing, where they're trying to study the same thing, coming to different conclusions. And so that's why I think the idea of having something that is definitively right or wrong is very, very fuzzy at this point, because it almost seems like the international medical community can't really agree on much of anything right now, because there is so much conflicting study output that's happening. And of course it changes almost on a daily basis as new studies are coming out. What we thought we knew a week ago is now false, and now we think we know something else, which might be false next week. And so this is and this is probably how all epidemics and all pandemics have ever gone. This is just the first time that we've really had the chance to study it, right? At least from
your back, Susan. Good.
Oh, yes. It's busy, I guess, evening time here, so everyone's on their internet, I'm assuming.
Unfortunately, that's the beauty of working remote, right?
Yeah.
What's that?
There you go.
I thought somebody was going to jump in. One of the other points that we had sketched down that we wanted to kind of bring up, that's not about COVID, but it's about a similar problem, that we do see happening in particularly among institutions that are trying to do the same types of things in other areas related to medicine. And this was a big one, because I think it was only a few years ago, if I remember correctly, it was the World Health Organization that effectively retracted some conclusions that they had made, if I remember, back in the 1970s. And what it was in regards to the I think ultimately including coffee as a carcinogen. And they finally came out a couple of years ago and retracted that study. And ultimately, I'm going to try to summarize it, but the conclusion as to why they redacted the study was that all of this that had always been done, it was always a meta-analysis, right? So they were looking at a bunch of tiny studies, along a very long period of time, that were done amongst different populations over decades, right? And so it was already something that I think was highly skeptical anyway, because of all of the same reasons that the data collection methods and the survey methodology and all of these are going to be different in every single study, and you're comparing hundreds of studies together to try to to come to an overall conclusion. But the ultimate outcome of why they said that they retracted it was that they had made I guess an incorrect adjustment, and they forgot to account for the idea, as it was in the 1970s, that a large majority of people that drank coffee also smoked, and they also smoked while they were drinking coffee. And so as they were trying to perform these analyses, they came to the conclusion that coffee was the cause of cancer, and we may not be right about this. It might actually be the smoking that was causing the cancer, not the coffee. And so the reason why I thought that this was particularly interesting is because this was a study results effectively that I was kind of raised under as a kid. So, this was something that I heard a lot about, and I was, my parents were reading these studies whenever they were coming out in the 70s and in the 80s. And this became how I was raised in such a way that I was raised to believe that coffee was a carcinogen, right? And I'm sure a lot of people were as well. Now, whether or not it is or it is not, I don't think that we know the answer to that. But I think what we do know was that the study methodology that they used to make this determination in the first place was flawed. And I think it was something that we could reasonably make that assessment that it was flawed even without them retracting it. And unfortunately, there's a lot of studies that are out there that are that are very similar to that. Whereas we're looking at very large population groups, and we're trying to pull a bunch of really small studies, pull them all together, and then perform this meta-analysis. Which I think in many circumstances, this entire concept of performing the meta-analysis is something that's flawed from the get-go for that very reason. And so I think that's a very practical example of at least an example of how it didn't work, and probably why it didn't work.
If I can jump in on that one, one of my favorite stories. There was a study that was done recently, basically a machine learning algorithm that was intended to basically look at medical records, and from that to essentially determine based upon the medical records, see if there was some way of being able to show, what factors would result or would show up as cancer. And so the people that were doing the analysis came across, a machine learning or set of machine learning systems for one set of data that was great. I mean, it was giving them like 85, 90, 95% accuracy rates. And they were going, this is wonderful. We've found a way of identifying who's going to be able to get cancer. I mean, this is Nobel winning. And then someone actually sat down and did the analysis. And they realized that all of the information that they had that had been fed into this data in the first place was basically coming from one particular hospital. And the nurses at that hospital had basically started a convention of every time that they were dealing specifically with a cancer patient, would put a little circle C up at the top of the medical forms. And so the machine learning algorithms were basically reading these, would pick up on that circle C and say, hey, look, there's a perfect correlation here. And, it was a great, to me, it's actually a very telling piece of information, or a very telling story about why you have to be careful with meta-analysis and why you have to be careful about what you're basically doing when you create models in the first place, especially models that essentially are, you don't have necessarily full control over what variables specifically are being involved in there. You get something where you're talking 50, 100 variables in a gradient descent type situation. At that point, it becomes very easy to get misled about those circle C's, about coffee being a carcinogen because, there's a correlation with smoking. And that's a real challenge with data, with medical data in particular, because nothing is cut and dried. I mean, we tend to think of data as information that is absolute and accurate, but it's not. It's basically just observations. And it's observations that we have to basically look at and understand from the perspective that these were basically made by people. They were made by people with different standards. I mean, I think Scott in the 7-Eleven example earlier today, provided a very good example of that, of saying, how many different ways do you enter 7-Eleven into a field? I've seen it myself, hundreds of times working with clients. So we need to also stop and think about the fact that the data that we're collecting is oftentimes, we have it is itself susceptible to language. It's itself susceptible to the way we think about information and knowledge. And so there's contextual information we always need to keep in mind.
I always talk about context, and especially in the kind of data that I work with, and I always say that you need a human there at the start and at the end of the automation to make sure that what's going through is correct. Maybe if someone had checked that automation process a little bit into it, then those little C's might have been picked up. Who knows? Yeah.
Well, and I think, that's one of the things that I know I stress when I talk to people about data collection in particular, is that, there's the tendency among businesses, among organizations, to want to say, can we automate this? Can we automate curation in particular? And I keep going back to them and say, no. I mean, you can automate some of it, but you really need to have a quality control person at some point, basically managing the kind of information you're dealing with. And this goes right back to what Eric was talking about, when we started this thing out. Quality control is really emerging as one of the biggest issues that we're facing with regard to the data itself.
Something else I would say that hopefully people will learn from, and something that I'm banging on about all the time, is the data quality part is a specialized skill within itself. It's not part of another person's job, not an analyst or a scientist. It's a very different skill set that you need for that, but that's not really been recognized at the moment.
Yeah. We don't like librarians. Nobody likes librarians.
I do. It's all about organization.
From what you were just saying, Kurt, one of the things that I just remembered that I think I meant to put in my notes, but I had forgotten, was this was a study that I think was done on COVID maybe 3 or 4 weeks ago, that came across on one of the preprint servers, where they had made the they had come to the conclusion that somewhere around, if I want to say correctly, it was somewhere around like 80% of the tests that were done were false negatives, whereas they were positive, but they didn't test positive. And what it came down to was there was a very strong and very obvious survey bias that they introduced whenever they collected the data. The manner in which they had done it is this was an organization that obviously they got a hold of a bunch of antibody tests, and they went onto Facebook and they said, hey, and I think this was in Los Angeles, they went onto Facebook and they said, hey, if anybody wants to get tested, they can come here, and it's up, we'll give you a test, we'll give you your results. Well, there's a number of issues with the way that they did it, because number one, it wasn't random sampling. And because it wasn't random sampling, there's actually a number of ways in which it could be strongly biased. Number one, it's going to be biased to the people that have the time to do this. That also means that they are probably either working from home or they're not working. They also thought that they had COVID-19. Otherwise, why would you go get the test, right? So that's another big issue with it. And it's also, highly skewed against people that are working in retail effectively, that are not going to be able to take the time off of work to go take those tests. So there's a whole number of issues that they introduced by the manner in which they got people into the study. And so obviously, we're looking at those results and thinking, wow, this infection rate is much higher than we thought it was. But, kind of with all of these things considered, I would almost look at that and say, how could we legitimately look at the survey collection methods and then come to any reasonable conclusion based upon what they had done? And these are the things that we, as we kind of dive into a lot of these similar types of studies, a lot of them are flawed in a very similar manner.
Mm-hmm. Yeah, the statistics is a bear. We tend to get so focused on the tools and especially people that are coming to statistics from the standpoint of being, hey, look, it's R, or it's even better, it's Python. Wow, cool. And they don't necessarily understand that you really do need to have a fairly clear grounding in statistical methods, in what is bias, what is variance, how can you get the information that you're working with in the first place to be able to mitigate these factors and determine what the error boundaries are of the information itself. And in the best studies, we have that information because the people working with it are trained, have training as statisticians. For many people, they come in from the standpoint of, well, we kind of assume that the numbers that we have are accurate, and that's a very dangerous assumption to make going in if you weren't specifically involved yourself in determining what the underlying biases were in the data collection.
I think to your point earlier, that's one of the issues that a lot of people in the data science community have with, for lack of a better term, what I would call cagglers, which are people who are grab a data set and then build a model off of it without any knowledge of how that data set was obtained, or be able to dive into any of the potential problems, like flawed survey methodology that might go into that data, and they're going to run with it, and kind of make conclusions. This is certainly not anything new that we're seeing. That's part of the COVID crisis. I mean, this is a problem that has existed, I would say really since the dawn of time, but it's becoming more and more prevalent with a lot of other kind of publicly available data sets, and it's resulting in a lot of flawed models, whether it's related to health or whether it's related to climate or whether it's related to international economics or something like that, because all of these problems exist in all of those in all of those scenarios.
Eric, I just need to chime in here. I'm hearing three versions of you. There's a lot of echo. It's coming mainly from you, but I don't know what's going on, but it's difficult to hear.
It's not too bad for me, but you were breaking up a little bit there. I don't know if that's you or me.
That's just FYI. I can hear my own echo.
Out there. Yeah. So, have you seen any other, any other studies that you guys have come across that that kind of looked to be, a very similar method where there was some very obvious data collection flaw?
I wouldn't so much say flaw, but if you look at the UCL predictive modeling that was done, that had a profound influence. The issue is that it's based upon predictive analytics for a problem that is not predictable. And it depends on the assumption. So you can get so carried away with the predictive modeling without understanding the context of an uncertain problem. And so that's where we have to be wary and look closely at those assumptions before we get too enamored by certain
the University of Washington study, which was one of the first out there, because we saw the infection first here, had a fairly significant impact on policy making at both the state and ultimately at the national level. And one of the problems that came out of that was that as you point out, and you're exactly right, we didn't have enough information. And as a consequence, the parameters, the uncertainty bars associated with the projections that we were making on this were large, and we knew they were large. But in many cases, what would happen is that policymakers would basically take a look at the baseline numbers, not look at the error bars, not look at the fact that you're basically saying, hey, look, this thing is, this thing has 40 some odd parameters in order to be able to make those particular judgments. And in order to be able to determine what those 40 parameters are, we have a very small sample on which to build on to be able to make those estimates. So, the people who put that study out in the first place recognized, look, it's an early study. Do not take these numbers as anything other than potential. But now, one of the things I heard, probably about a month after was, well, look how wrong that particular study was. No, it wasn't. It's actually has been pretty accurate given the information they had at the time. But it is not something that, it's data education that needs to happen. You need to be aware of the fact that predictive modeling is only as good as the data that you have. And if you don't have enough of it, if you don't have enough of the right kind of it, then your models are going to be flawed. It's just like
I would argue even if you have good data, there's the restrictions on the predictive modeling as well. And I think it's easier to simply say there are 3 case scenarios. Assumptions that affects the minimal, middle, and max. And the max, we have to prepare for that. I mean, that's what New York City has.
Sadly.
Yeah. I mean, that's a communication issue, which is independent of data. It's really just common sense.
It absolutely is.
Common sense. Oh, sorry. Except for the fact that common sense is often not. The similar issue basically came out at one point because a number of these studies were basically using log data or logarithmic, log or even log linear data. And, people looked at that and said, oh, well, that's not too bad. Until they realized that, what they were looking at was not something that was, oh, maybe, this is 2 times as bad. It's 20 times as bad. It's just that you're looking at it in the wrong scale. And the behavior is different because a logarithmic scale is not a linear one.
So something that I was talking about last night was how things are reported in charts and graphs and things, and how that's interpreted by people. How do you think that's been portrayed to the general public? Because I think if it's not portrayed in the right way, they're going to misunderstand or misinterpret the data, or they're just going to or it's going to be too complex and they're just not going to even look at it and possibly not make the right decisions.
I found there was an excellent chart that came out from the New York Times, basically showing the impact of how many people basically applied for unemployment, and it actually was animated and would show these fairly consistent bars. Showing, up and down scales, 2028 and 2008, and you got, the collapse that occurred there, and you could see that, and you hit what happened in April, and you watched as the whole chart basically disappeared, with the exception of this one spike that just went going up and up and up and up. And I think that was more telling. A similar thing basically was used recently in print. It was far more telling to just kind of indicate the true magnitude of things, even though, you lose detail in terms of the the scope of what happened in the past, it was a terrifying graphic because it really kind of showed, hey, look, a lot of people are out of work, more than in the Great Depression, suddenly without jobs. This is the same thing that we're running into with COVID. We need to be very careful in thinking, part of the role of a data scientist is being a communicator, of being able to say, this is the story that the data tells. And if they're not communicating that information in the right way, if they're basically assuming that people understand statistics, understand graphs and mathematics, they're going to get the communication wrong. So I think there's a lesson for the data science community as well here.
And so for this panel, we have 5 minutes left. We did have some things that we wanted to dive into, but the overarching message here is what are there any specific lessons that we can take from this into our own organizations that we might be working on a day in and day out basis and having a similar type of problem? How can we take those lessons and apply those to our company?
Go ahead, Susan.
No, I'm just.
Oh, okay. My own thought is that we as data professionals need to acknowledge the fact that there has been a lot that has been revealed that we've fallen down on. I think that in some cases we've actually done a job given the speed at which this thing has occurred. But at the same time, there's been a lot of assumptions that we have made going into this that have proven to be wrong, have been proven to be not necessarily inaccurate, but also not necessarily representative of what reality actually is. And so I think that some soul searching needs to be done on the part of the data science community and the data professional community. Some of it needs to be thought of in terms of how is it going to affect our thinking with regard to privacy issues? How is it going to affect our thinking in regard to, the role that data plays in policy? And, some of it basically is, comes down to the question of how do we basically assure that people who are representing themselves as being a data professional are actually truly professional in what they're doing. And so, I think that a lot of this, I don't think that there are any answers that have come out of it, but I think there are some questions that we need to be asking ourselves. That's my thought.
Short and sweet for me. If you got one takeaway from all this, consistency, make it consistent across the board, and that's a really good starting place.
And I would simply add on top of that, make it actionable. Yes. Data without action, even it's good data, is useless.
Gary?
You on mute?
I was screen sharing here. It was it had my. I was going to show you another visualization. These are some of the ones from our wall of shame. This is an NBC one about the Zika virus. Yeah, there's a lot of great ones in here. And there's a ton of pie charts that don't add up to 100%. Oh, this is a great one. This is on a bag of dog food that is made by a company that's in our area. I took a picture of that. It's not really a data visualization, but I thought it was very.
Hey, it's got to be good. It's got 116% of the whole food you need.
Oh, and here's a great one. This is from this. I'm trying to remember which
Wow.
organization puts this out. This is a pie chart that's a very odd pie chart, and not real. We don't really learn a lot from it. But no, there's a lot of really egregious ones in here.
Wow. Whoa.
100 most active leaders.
Well, that's useful.
Yeah, exactly. We learned a ton from that. You know, this is
Eric,
here you go. Here's one more one.
I'm so much better
I've got a
about
whole
myself already.
library of these. The thing is, a lot of them are from universities. That's the scary thing.
So I classified a lot of university spend data, and they write in their descriptions, and the spelling is atrocious from the universities. I cannot believe.
There was one. We don't have time to find
Absolutely.
it now, but I'd love to be able to add to that. It's this picture of a whirlwind of a graph in 3 dimensions that has kind of helical patterns. And I don't even remember what the graph itself was, but after looking at it, my conclusion is it was basically a re-rendering of the Wizard of Oz, and each of the different paths were the paths that Dorothy and the witch and Toto and everyone else took, including the follow the yellow brick road and all that. You may have seen it. It was on recently, but I'll have to add that in. Purely stunning about how useless it was as a piece of graphical information.
And the scary thing is that these to influence people, right? Whether or not it's in a news article, or whether it's something that a college is using to justify its own admissions program or something like that. All of these things are used to present to some stakeholder somewhere and influence someone's opinion. That's the real scary thing. So you're absolutely right. It's data quality, it's QA, it's all of these things have to go into this before we can have any useful machine learning or predictive models or analytics or whatever we want to call it, right?
Yeah.
Excellent. That is beautiful. Well, we are up against the wall on time here.
Sounds good.
Sounds great, guys.
Thank you very much, Scott.
We'll catch up soon. Thank you, guys. Thank you for participating.